So the topic is complications third space endoscopy, and let's start with the definition of third space. So we know what is the first space, and we know roughly what is the second space, which is the space that we can work in using a tiny scope like a cholangioscope. And finally, the third space is a space that requires that we create an opening in the wall of the GI tract, that we work either in the submucosa or outside submucosa. So the submucosal space endoscopy started about 10 years ago, thanks to the innovation thinking of two true pioneers that reported first in GI endoscopy and afterwards in endoscopy what can be the potentiality of accessing to the third space. And this is the video of Jai Pashriska commenting its first attempt in the live pig in doing myotomy. You see, he was showing this video, which is historical, that's been taken in 2006. And you know the story, when he met in 2007 with Haru Inoue, they discussed about a poem, and Haru Inoue started doing the first poem in 2008. And this is Pastrika. Sorry. So, but the third poem in the beginning was poem, and this is Pastrika and Inoue just discussing in front of a good Italian wine about who was the first.
Call poem. So in my memory, he came up with the name poem. I was just calling it something else.
Yeah. So sorry.
No, it's okay.
No, but that's true. And actually, I read your paper in endoscopy. Yeah. After that,
2007.
Really able to start.
Yeah, but you were there for that. That talk was about the paper. Basically, the paper was just.
2006 or like that.
The paper was 2007.
2007.
Right.
Yeah, right.
Paper
after.
came right after that meeting.
Yeah.
So what was your feeling? We have to go there?
Yes, we have to go there. No doubt.
So when you did your first?
Huh?
You remind when you did your first
Yeah,
case?
of course, September 8th, 2008.
So it took 1 year.
September 8th.
And before doing your first human case, you did some animal lab?
Yes.
How many labs?
Not so many.
0 lab. Just one.
You
didn't do any lab.
Just one in my mind.
Oh, that's great. So the truth is, never did an animal lab. He did straightforward to the patient. Was great. So after poem, there is a long list of procedures that have been performed using tunneling at third space endoscopy. So we remove submucosal lesion, we can treat gastroparesis, and so on. So just to give you the feeling of what we're doing, because when we present these kind of videos in surgical meetings, we always start fighting with the surgeons because they do not accept that we're doing this kind of stuff. But this is a simple example to show how we can deal in the third space, in the submucosa, or out of the gastric wall in a patient with the gastroparesis. Here we are performing very carefully selective myotomy at the gastric side. And also, this is a nice video to show how accurate we can be in removing GIST lesion into the esophagus. Especially this is true for lesions located in the gastroesophageal junction, where laparoscopic approach is very challenging, and endoscopy can do a very superb job, especially for lesions which are smaller than 4 centimeters, because bigger than 4 centimeters can be very difficult to get out of the mouth. So this is the final step of the removal, and most of the time you cannot recognize the attachment to the muscle, so you have to use a snare to catch entirely the lesion and remove it. So, and afterwards in 2016 in gastroenterology, the Chinese guy presented for the first time this concept of Z-poem, so of zinc treatment using pharyngeal access, creating a submucosal tunnel to cut the septum, the muscular septum that creates the Zenker, and we are doing a little bit of modification of this technique. We change the technique, we call it this POES, peroral endoscopic septotomy, and in the sense that we just cut the mucosa on the top of the septum alongside the long axis of the septum, and once we create this tiny incision, we try to get in like we do with the point procedure, and we look to the septum and we start doing septotomy from the beginning, you see. And more we do the septotomy, more we go down into the submucosal space and keep cutting the cricopharyngeal muscle. So it's important when you do that poem that you use the smallest scopes available, accepting this kind of device. Now we are also using a transnasal scope because the Fujifilm latest generation scope has a working channel about 2.2 millimeters. So we are using this kind of scope also for doing a minimal access Z-poem with a tiny scope. And it's difficult to understand how far you can go. Normally we go until we see that the muscle layer is very thin. So we imagine, we think, we guess that the kind of muscle thickness is the normal muscle layer, like you can see here. At this point, the muscle is very, very thin. And the nice part is that when you have to close, having done this cut on the septum, it's very easy to put clip and close the mucosal opening. The last proposal in terms of submucosal tunneling comes from another super smart guy who is Peter Dragunov. He reported first in GI endoscopy this approach with the two scopes to create a tunnel to try to treat patients with a complete esophageal obstruction due to severe stricture. I never tried this. I think it's extremely challenging, but the results that they reported were very, very good. So what is the issue with the complications in POEM or in general in third space endoscopies? So the first point is that there is a complete lack of standardization. We are completely missing guidelines to try to have a standardized approach to this procedure. So if I ask all of you doing POEM, are you giving to the patients antibiotics the day before, the day after, for how long, how much you're using in terms of PPIs, you use painkillers in your postoperative protocol for treating pain, whatever. So there is nothing standardized. And also, when you look to the definition and the management of complication of POEM, since it's a completely new topic, there is a huge variety of approach. So if you look to the management of patients with antibiotics, I reported a couple of big papers reporting experience on thousands of patients, and all of us is doing differently. So who is giving antibiotics just the day before, who is giving for 7 days. There is no standardization. And I think there is a lack of knowledge on the potential risk of bacteria translocation because we are going from non-sterile to sterile space, and probably we need to work on that to understand whether or not we are contaminating somehow the extraluminal space. Also, definition of complications in POEM is very tough. So I looked to different papers and articles, and I tried to summarize what has been considered a complication of POEM. So the adverse event has been considered any symptomatic event related either to sedation, anesthesia, or the endoscopic procedure per se, requiring a temporary stop of the procedure or a further activation to solve the event or to treat the symptom. So of course, Inoue was very systematic in addressing the issue of complication when in 2016 he reported in endoscopy all the endoscopic complication he got in patients with POEM. So we started talking about mucosal injury and mucosal perforation, tunnel descents, and bleeding, pneumothorax, and pleural effusion. So what about the complication rate? So this is a nice point. When you look to the papers coming from the Chinese authors, they tend to underreport the complications of POEM. And I do understand why they do this, because probably they are referred with the patients coming from very far away, and they are collecting cases from people who are as distant as 2,000 kilometers from the referral centers. They lost the follow-up of these patients. So probably they are underreporting the complication, not because they don't want to report the complication, but because they are not aware of the complication. So they reported this large series, and they say that it's about 3.3% incidence of complication. When you look to a large series from, we'll say, Western consortium of people doing POEMs, we saw the overall incidence of complication is twice higher, it's 7.5. And if you look the difference between mild, moderate, and severe, we can expect 0.5% of severe adverse event. It's difficult to understand whether or not there has been death associated with the POEM. I must tell I did extensive PubMed search. I couldn't find a single POEM-associated death. I know for sure that there have been a couple of fatal events during POEM, both in the United States and in Europe. It's pity we are not reporting ourselves. I think it's our duty to report this, because it looks like that POEM is associated with a 0% of mortality. I'm not sure this is completely true, and I do apologize for not being able to report what is the real incidence of mortality in this situation. And of course, when you look to the papers reporting complication in POEM, we ourselves, we do consider a number of different situations like capnoperitoneum or capnothorax as a simple situation that can happen after POEM without any clinical relevance, which is completely different if we get a capnothorax after standard therapeutic procedure into the esophagus. So also very important presentation timing. If you look at the papers, most of the complications are reported as immediate during the procedure. And we have the other about 40%, which may happen within the first 48 hours, and limited number of delayed complications. So I think this is a little bit changing. At least in our experience, we are seeing more and more complications that come to us after 3, 4, 5 days from the POEM procedures. So also, when you look to the severe adverse event, you should be ready to discuss from the beginning with your surgical colleague. Normally, I expect the center doing POEM is associated with a good surgical team, either thoracic surgeon or GI surgeon dealing with the esophageal surgery. And when you look to the severe adverse event, you can realize that most of them may require a surgical approach, a surgical correction, because sometimes our capability, especially with the clips, to close the mucosal leak is not that perfect. So there are factors that can predict the risk of adverse event in third space endoscopy. So at least for POEM, we have a number of different factors which have been associated to the increased risk of adverse event. The first one is anatomical situation. If the esophagus is very dilated, very big, it also means it's very long history of achalasia, you have increased risk of complication. The other point is the skill, the expertise of the physician. So normally we say that you have to list have been performing at least 20 procedures under tutorial, and you should do at least 20 procedures per year to keep your skill updated. And there are also a couple of technical issues which are related to the devices or the generators setting that we use. Have been reported that using the triangle type may increase risk of perforation as compared with the hybrid knife technology, as well as has been described that the use of current setting different spray coagulation may increase the risk of perforation. So this is very similar in terms of incidence when we look to the data coming from paper reporting the retrospective series of submucosal lesion removal. There are no prospective series. About 80% of the data, they are still coming from China. And you see in the beginning, data were not that good because complication was as high as 25%, and going down, they improved their ability to prevent complication. This is the latest paper I could find in the field of STER, of submucosal endoscopic resection. It's been recently published in American Journal of Gastroenterology. And what the authors say, they say that perforation is one of the most common serious adverse events. It's more likely to happen when you are removing a submucosal lesion nearby or in the region of fundus. You can treat them by endoscopy, either using clipping or suturing device, but you have to be prepared to refer to your surgical colleague at least 1/3 of the complication happening in that area. So this is our own experience. We start doing a poem in 2012. This is the last 5 years experience. As you can see here, we are growing every year with the number of poems. Now we cannot stop the patients for asking poems. So even though we propose laparoscopy or we propose pneumatic dilation, I do believe it's still a fantastic procedure to treat patients with achalasia. It's very difficult to convince the patients to go back to, I would say, old-fashioned approach. All of them, they want to be innovative. They want to have a very sexy procedure because everything is endoscopically done. They do not have the complete feeling on what is the real situation with poem and the fact that poem can expose the patients to the same risk of complication as well as surgery. We have done very few G-poem. We do about 2 or 3 cases per year, and we do a lot of Zenker patients with the POES approach. Especially we select the POES for those patients with short septum, because when we have short septum, we try to do traditional endoscopic septotomy. I do believe we are not able to cut the septum properly. We do very short cut, and this is not enough. And in the beginning of my approach to Zenker, I was convinced that short septum means 0 symptoms or low symptoms. Indeed, many patients with a small Zenker diverticulum and short septum, they have a lot of symptoms. Sometimes even more the patients with a big Zenker diverticulum. So it's important in these patients with short septum that you proceed with third space endoscopy. You cut the septum down, all the way down, to make sure you are reducing the risk of recurrence. And you see the complication number, we have about 2 or 3 patients with adverse event. When I say adverse event, I mean serious adverse event in this space of the third space endoscopy. And I want to share with you the complications that we got over these last 5 years. We had about 7 cases of esophageal leak, 3 cases of a pleural effusion infection. Even though we were not able to identify the mucosal leak, was not evident, there was no mucosal leak, and with 2 cases of severe bleeding. So let me show you a couple of these cases. This was a standard patient with type 2 achalasia, and we did posterior poem because he had a very big sigmoid esophagus, and looking to the anterior approach, I couldn't realize what was my trajectory to reach the cardia, so I found much easier to go on the posterior side. And in the day after the procedure, he started having some fever. It's important, you can recognize here, I looked to the X-ray, I could recognize that there was something wrong with the clips. So it's important, simple floor examination. You don't need CT scan immediately, but you can have a couple of items to be looked to consider, because this is a very bad sign. So it means the clip that we have placed, they are not all in the right position. So the patients was having even more fever, he became septic, and you see he had the big pleural effusion, and when you look to the clips, they were falling down. The clips were not in the right position. This is why we did the CT scan. You can see how big was the esophagus. There was big mucosal leak. Only 2 clips remained there. You see 1 and 2. You can recognize the 2 clips on the CT scan. We tried to close, so we removed all clips, and we tried to reclip again, but our feeling was we were not able to seal off that kind of leak, and we referred the patients for surgery. This is the picture from surgery. It was thoracotomy plus washout plus drainage. They didn't suture the esophagus because they thought it was not necessary, and the patients did extremely well. He was discharged 10 days after, and you see we put a lot of clips on the side of the previous esophageal leak to secure our esophageal mucosa. So this is another patient. This was a very sick patient that was refused by the surgical team for laparoscopic approach, and was referred for anterior poem. We did anterior poem, was very nice, but in 40 hours the patient developed fever, a sign of infection, sepsis, and a lot of chest pain. This was the patients with, I would say, most important feeling of chest pain that we have got in about 350 patients with the poem. Was really untractable, and we did endoscopy. We saw this big mucosal leak, and the problem was probably when we did the mucosal incision, we used too much cog, because there was a tiny bleeding on the sides, on both sides of our mucosal opening, and this created a late damage on both the mucosal side, probably on the deeper side. We got in, there was a lot of pus, we cleaned everything. This cavity was not in connection, we felt was not in connection, completely in connection with the pleura. It was a sort of space organized by itself and full of pus, so we did a big lavage, we cleaned up all the debris. We placed a large bore stent, the one that we used to treat post-bariatric complication, and which is 24 millimeter in diameter. We left for 3 weeks, and the patients did very well. So this is another complication that came to us after 1 day. So it was complicated patients because he had several times dilation, about 5 times botulinum injection. I'm not sure that the cause of complication was that, but just to give you some prediction, some factors that can predict the risk of complication, he developed 7 days afterwards, he started having symptoms, and 9 days after poem, he came back to the emergency room. We did the CT scan, you can see we did endoscopy. We could recognize that all clips are fallen down, and there was a big opening to the submucosal tunneling. So we placed 2 different nasogastric tubes. One small size nasogastric tube was placed into the tunnel, and the other one was placed nearby, so in the esophageal lumen across the gastroesophageal junction. Both were put under mild aspiration power and were left for 10 days. The patients did extremely well, but 10 days after, he developed a severe bleeding. So he had hematemesis, anemia, shock, and we did endoscopy immediately. We did emergency endoscopy, and because of the nasogastric tube and tunneling, the bleeding was caused by probably another mucosal leak just created by the tip of the nasogastric tube lying down into the tunnel and creating a second mucosal opening at the GI junction. We saw the bleeding, we treated the bleeding with the COA grasper, and afterwards we clipped again the mucosal opening of the poem. We clipped it on the GI junction side, and the patients did well. It was discharged in 6 days. This was the most difficult to manage complication after poem was again achalasia type 2, anterior approach, 8 hours after the procedure. So it was normally we do poem in the afternoon. Every Monday we have 3 slots for poem because according to our regulation we get reimbursed from the National Health System only if we perform poem in the operating room. If we do in the endoscopy room, we don't get paid. So the slot that we have assigned by our surgical colleagues is just Monday afternoon from 1 p.m. to 8 p.m. So, but this is good because we had no other chance to do that. So it was there was the last case of the day. So it was a late afternoon, and the patient developed the complication around 4 o'clock in the morning, and he had a severe bleeding and had a big drop of hemoglobin, 8 points down. So we did immediately CT scan before endoscopy, and we could recognize, you see, this big hematoma that was inside the tunnel. I don't know if I have a video. Yes. And this is the video of the endoscopy. Okay. So we couldn't find any esophageal leak, you see. This is submucosal hematoma, huge hematoma. And look now, the hematoma was opening a big hole at the GI junction on the gastric side of the GI junction. So there was a big protruding clot with a big mucosal opening. I tried to move the clot with the snare, and next to me there was my surgical colleagues. He was illuminating, saying, probably it's much better if we leave the clot over there because it's creating a sort of hemostatic mechanical compression on the vessel. If we remove the clot, we may risk we have ongoing bleeding. So we left the clot as it was. I just touched it briefly, but he said, okay, please stop that. I followed, I nicely followed the suggestion. It's incredible. If you look to the picture 2 weeks later, it looks like nothing. It's really incredible. So sometimes this video is to give you a message. Sometimes it's much better to have a very conservative approach rather than having operative approach. It's extremely important when you do endoscopy for severe complication of poem like this that your surgical colleague is next to you. So having this kind of in-time consultation with the surgeons can save a patient's life, but can also give you a better opportunity to reconsider what you're doing, because our ego is a little bit high, very, very high, and we believe we can solve everything endoscopically. Sometimes we need to stop and look to the surgical alternatives. So in conclusion, we have an issue with the lack of standardization and confusion in definition. There is a sort of gray zone in the space of a third space. I think that in the future, experts, they have to come up with a sort of review papers or guidelines to address all these topics. The serious adverse events have to be expected in a significant number of patients, even though these are not leading to mortality, but 3 to 5% of our patients can develop this kind of situation. Mucosal leak is the most frequently reported serious adverse event, and there is not a standardized approach for this kind of complication. It's a tailored approach based on multiple factors, including the surgical skill available in your hospital, and just consider that 10 to 20% of patients with a post-POEM or post-third space endoscopy complication may require surgical approach. Thanks for your attention.
Yeah, thank you for the interesting talk. Time is a little bit advanced, so maybe one question. If I may, so do you have a system in place to make sure you get long-term follow-up for all the patients where you do these more invasive types of procedures?
Absolutely. We have a superb follow-up system for them. We have a research nurse calling the patients on a regular basis, and we are following all patients systematically. We are the only centers that have pH and manometric data every year for 5 years for the first 100 POEM patients that we have done, and we are going to publish this data. We pay a lot of attention to this.
Yeah, great.
Thank you very much. I just have two things to discuss. One thing is I appreciate very much that you addressed to the indication for Senka with the short cricopharyngeus muscle. Because the more these things are done, the higher is the rate that we have to reoperate. And I did 2 weeks ago a patient who had 3 attempts of endoscopic Senka diverticular treatment, 3 attempts. And when I operated him, he had a very nice Senka diverticulum, which was a bit more difficult to reoperate. Concerning the peroral endoscopic removal of the submucosal lesions, as far as I follow these Chinese series, I mostly see that
leiomyoma.
The indications is
yeah,
very
you're right.
discussable.
You're completely right.
And I think it's more like, you know, the old saying, if you have a hammer, a new hammer, everything looks like a nail. And they remove everything. And
You're completely right. You're completely right.
If you look at your series, they measured 19.2 millimeters is a difference. So I think very discussable.
You're right, completely.